My name is Kirsty Roberts and I'm a trial manager at the University of Bristol. In this short video, I'm going to take you through the lessons that we learnt from the HepCATT randomised controlled trial. We hope that our findings will be useful in informing the planning for the NHS England rollout of hepatitis C case finding in primary care. HepCATT was a randomised controlled trial of hepatitis C case finding intervention in primary care. It consisted of a multi-component intervention, which included an algorithm integrated into the electronic patient record systems to identify high-risk patients, an automatic mail merge for patient invites, pop-up alerts in patient records to encourage opportunistic testing, practice staff hepatitis C educational training, and finally patient posters and leaflets explaining hepatitis C risk factors and treatment options. So what were the main findings from HepCATT? We found that the HepCATT intervention had a modest increase in testing. 5% of patients were flagged with hepatitis C risk markers in the intervention GP practices. 16% of the flagged patients were tested for hepatitis C in the intervention practices compared to 10% in the control practices. This was a 59% increase after adjusting for the characteristics of the different practices. We also found that the HepCATT intervention was highly cost-effective. The average cost of hepatitis C case finding was £4.03 per at-risk patient. The cost per additional patient assessed at hepatology was £3,165, and the cost per quality adjusted life year was £6,212. We also interviewed a number of practice staff who took part in HepCATT. We found that practice staff highly valued the intervention as it enabled them to systematically identify patients with risk factors. It also enabled them to have a comprehensive list of patients to target for testing. It also enabled them to identify patients with risk factors that the practice may not already know about. And it gave them the opportunity to discuss testing with patients, especially those who may not have been aware of hepatitis C risk. So our conclusions from the HepCATT randomised controlled trial were that we recommended that the intervention should be optimised and rolled out across the NHS. So here are some of the lessons that we learnt from HepCATT. Training. Practice staff valued the training that we provided in HepCATT. It enhanced their awareness and knowledge of the associated risk factors. It also prompted staff to have opportunistic discussions with high-risk patients when they saw them. We did find, however, that some practices had limited IT resources and expertise. We suggest providing practices with clear instructions and training to support them to use the intervention. Screening lists. Practices need to consider how they will check the list of patients with risk factors. The list checking in HepCATT was costly as it was mainly carried out by GPs, but some GPs felt that it was necessary. However, in some practices we found that list checking was carried out by practice administrators, or the practices drew on the expertise of nurses to reduce the GP workload. Managing resources. Practices did raise concerns about the increasing workload that may be associated with sending out the patient invite letters. However, in HepCATT we found that practices tended to send out the letter in batches. They were also provided with extra funding to cover the time and the cost of sending the letters. Practices were also concerned about the increase in demand for testing following the invitation letters being sent out. However, during the study, no practices reported being unable to manage this. Opportunistic testing. GPs did not generally find the pop-up alerts to prompt hepatitis C testing helpful during HepCATT. However, some nurses viewed the reminders positively. GPs felt it was sometimes a challenge to fit in an opportunistic discussion within a 10-minute consultation. GPs and practice staff said that greater general awareness of hepatitis C amongst the public might make having these conversations easier. Practices within HepCATT could decide whether to adopt pop-ups or not to aid opportunistic testing. Pop-ups can be managed at both the practice and individual level to ensure a balance between adequate alerting and burden. Thank you for listening to this short video about the lessons that we learnt from HepCATT. If you would like any further information on HepCATT or help with the planning of the national rollout, you are welcome to get in touch either with myself or my colleague Claire Thomas. Details of the publications from HepCATT are also listed here for further information.